All right, so this is how I typically dry needle patients for plantar fasciitis. And what this is an 8-point protocol that includes both perineural and periosteal pecking here. So I have Kyle as my model. And then what we did was we took some time to basically draw out the landmarks. Best we could. I think it's pretty accurate here. And so what I'm going to do is start here, and this is the tibial nerve. And so the first needle is going to go in this deepest gutter just posterior to his medial malleolus. And I'm going to do a follow-up video where you actually see the needles in place, but I'm typically going to take a very thin 30 millimeter needle at the absolute longest, and I'm probably going to insert this one about 15 to 20 millimeters down. And then we'll start to trace this, and then once we get past the bifurcation, that's going to put us into the medial plantar nerve. Now, this is a semi-standardized protocol. So this line here, the way you can actually find that on a real person is you kind of have to observe and see where the skin changes color. So, you know, for some people, it's going to go from like a whitish to a pinkish. If you have a black person, it's going to be a darker brown to a lighter brown, but it should be a very clear distinction. And that's where that nerve is going to run, and that's where you want to insert the needles. And what we do is we use anatomical landmarks so that way we can repeat it over and over again if it works, or the next therapist can repeat it. So this X right here is going to be the sustentaculum tali. This one here, we're going to find the navicular, and we're going to insert a needle right into there. This one, we take the time to go into where the tarso-metatarsal joint is. And then this one is going to be just proximal to the first met head. And then if we come around to more of the plantar surface, this line here should be the line between the medial and lateral plantar nerve distributions. So what I do here is I just take the foot and I'll just kind of squeeze together. We're going to find that midpoint right in between the two met heads there. And we're going to go right in. It starts to get a little more sensitive, but again, it's a thin needle, more superficial. This one, what I'm going to do is I'm going to find the most distal aspect of his calcaneus. And then I'm going to go 2 thumb widths or 3 finger breadths distal to that. And we're going to go right to where that plantar nervation boundary is as well. But then the one we need the most, because all the rest of those were perineural, now this becomes periosteal. This is going to be somewhere along the medial calcaneal tuberosity. So I just call it search and destroy. Most of the time the patients have their first step pain right on that medial aspect. Sometimes it can be a little more central, we'll call it, but I want to find where the epicenter of that is. And then what I typically do is I'm going to grab a 50 to 60 millimeter, and we're going to go down, get through the skin as quick as we can, because that's where the stick pain is, and we're going to keep going till we hit bone. And then once we're there, I then do a little bit of periosteal pecking. At that point, it tends to feel more like a toothache to the patients, and then we hook it up to stem. So again, I'm going to do a follow-up video in a minute with the needles in so you can see that. Okay, so this is just a quick example for how we do those perineural needles, and I used the foot that doesn't have markings on it because I wanted you to be able to see where that line is, where the skin changes color, because that's where you're going to follow it. So this is the third needle in the 8-point protocol. I'm going to find that navicular. I'm going to go south of that. I'm going to find that line, and then I'm going to go ahead and pop that needle in, keeping it fairly superficial, 15 millimeters at the deepest, and then I'm going to just do a little bit of rotation side to side. I'm not doing the aggressive tenting because I just want to let the nerve know we're there, but I'm not trying to pierce it. And this is the last one, so this is much, much different. These were all very thin, superficial. This one's a little bit thicker, and it's deep because we're going till we hit bone. So if Kyle was actually a symptomatic patient, I would again take the time, find the most painful spot, and I'm gonna go right into that. There's different ways to hit that medial calcaneal tube. My preference is to go straight onto it. So I let them know ahead of time, there's gonna be a little bit more stick pain on this, those pain fibers in the skin, but we're gonna get through that quick. And then I'm just gonna peck around the bone, and that should feel like a toothache. You good with that, Kyle?
Yes, sir.
All right. So assuming this is where it would be hypothetically, we're gonna get right through there. I'm gonna thread that in, and now we're on bone. And I'm just gonna peck around on that a little bit. How does that feel?
Fine. Toothache is a good descriptor.
Cool. And then we'll let it go. When I can, it tends to be more preferable to hook up E-stem to this. And so for Kyle, we have all 8 needles hooked up, and I have this on 2 hertz. And if he was a real patient, we would let this ride for 10 minutes. Typically, we're gonna do something like 10 to 15 minutes for extremities and more 20 to 30 for spine.